overdose. A narcotic is a respiratory depressant and a depressant drug, so typically the people are unconscious, typically either barely breathing or sometimes not breathing. And that's sort of the what we call a toxidrome, or the group of symptoms that would be consistent with a narcotic overdose.
And again, if anybody, as we move through from the audience, has a question, just raise your hand. We'll pull that question out as we do move along here. How common is it to see an addict or overdose, and those are really maybe two separate figures, report to the ER, say, within a month span on average?
I can tell you that I see someone daily. It's a daily problem. Yeah, I actually worked today before coming here, and I saw a patient today with a narcotic overdose. I think it's at least once a day, once a shift. It's a very prevalent problem now.
Can you tell us about any standard protocols or procedures as you assess or treat that overdose situation?
Well, again, if we're talking about narcotic overdose, the treatment is, as everybody sort of discussed tonight, naloxone or Narcan, which is an antagonist to the narcotics, so it blocks the receptors at which the narcotic works. So it essentially reverses the effects of the narcotics. The problem with Narcan sometimes is that whatever they've overdosed on actually lasts longer than the Narcan. So eventually the Narcan will wear off, and whatever toxic overdose or substance they have on board the symptoms may return. So, a quick fix with Narcan, of course, obviously reverses the, the initial overdose, but then we have to kind of watch them to make sure that whatever they've taken doesn't come back.
Is there any sort of set time frame? Is Narcan average about, is it a 10, 15-minute fix, or does it really vary?
Well, the half-life of Narcan is relatively short, maybe a half hour, an hour, and again, depending on the dosage, the overdosage of narcotic, it could, what we call rebound. So when the Narcan, when the naloxone wears off, then the effect of the opiate comes back.
When your role is completed there at the hospital, is there any protocols before discharging that patient?
Well, certainly we, talk to them about treatment, getting into a treatment program, or at least offering that option. There are some, there is some move now to prescribe Narcan or provide Narcan when we discharge them, so that if they've abused or used before, then, chances are if they're going to go back to that activity, then at least they'll have the Narcan available to them, as an outpatient.
Doctor, is there any agencies or protocols on reporting the cases of overdose?
As Dr. McDonald showed, we now report not only deaths from overdose, but now anytime we use Narcan in the ER, so we can keep track of numbers of, not just people who are unfortunately die from the overdose, but actually how many people we are treating for overdose.
Thank you, Doctor. I'd like to start the next question off with Michelle Hodder, from Anchor Recovery and Community Center. Can you talk about the role of a certified recovery coach?
I will, but first I'd like to expound a little bit on what John was saying about the emergency rooms. Right now, Anchor Recovery has a program where we are in several emergency rooms throughout the state of Rhode Island. We started in Kent County Hospital, we moved to Merriam, to Memorial, and now we're in Rhode Island Hospital. This weekend we will start in Newport Hospital. And what we do is we're notified by the emergency room staff, physician, practitioner, that there has been an overdose admitted, and we are called, and one of our recovery coaches is sent to the emergency room to sit and talk with the patient as well as the family of that person, to give them an idea of what treatments are available for them, where they can go to talk about this, whether it's a 12-step fellowship or whether it's some kind of treatment program, intensive outpatient program. I mean, the list goes on and on and on. And I'll tell you, last weekend in Rhode Island Hospital alone, we responded to 12 overdoses. no deaths, thankfully, but there are 2 people in the Rhode Island hospital at this point in time that are both in a coma due to overdose. Does it help? We don't know yet. It's a little young in the process. It's only been several weeks. I can say that it certainly can't hurt, that at least someone from the outside comes in and says, hey, look, I've been where you are. Most, if not all of our certified recovery coaches have experience, are either, an alcoholic or an addict, someone in recovery, and can just say, I've been where you are. There is help available for you, and rather than just, give them the Narcan and put them back out on the street, and that's not directed in any way to anything that the hospitals are doing, but they have a little bit better understanding of what's out there for them. So they might be able to make, a phone call the next morning that says, hey, you know what, I need some help. So we're hoping. So as far as your question about, certified recovery coaches, that's one of the roles that we are dealing with at this point. At Anchor, in 2 of our facilities, the one in Warwick and the one in Pawtucket, we have recovery coaches on site during business hours, 8 a.m. till 5 p.m., 5 days a week, and on Saturdays. What we do is sit down, just like we would in an emergency room situation, talk to people about where they want their recovery to go. It's different from a traditional kind of 12-step sponsorship in a way that we try to encourage the person to make their own path of recovery, whatever that may be for themselves. So whether it's a 12-step or a faith-based or a smart recovery or something like that, because what we're finding is that not everybody accepts or does well in a 12-step program. It's just the way it is. There's an expression, what helps me may kill you. So it's dependent on what that person needs. We also sit down with them, help them with resources, education. Maybe they want to get their GED. Maybe they're having some domestic violence issues. We put them in the, point them in the right direction for that, and try to take away the stressors that come along with being newly sober and clean. It's a long process, but well worth it for sure.
It sounds like something that is very beneficial. You mentioned some of the on-call locations, but it'd be nice probably someday if every hospital could have a certified recovery coach on call.
That's the hope. I mean, right now we're only in the emergency rooms from 8 p.m. on Fridays until 8 a.m. on Mondays. Obviously, the weekends are unfortunately the busiest times, but we have started from Rhode Island Hospital getting calls during the week. So we're looking to expand on all the programs to provide a, kind of a 24/7 service to people that are struggling with this addiction, the overdose problem, the heroin addiction, the alcoholism, just addiction in general.
Deputy Chief Perot, we've heard the word Narcan used quite a bit this evening. Who's carrying Narcan today? Is that something that's pretty much standard?
As far as the city of Woonsocket goes, 3 rescue companies carry, they're fully advanced life support capable. All 4 engine companies, as well as the 2 ladder companies. So if the rescues are tied up, your neighborhood firehouse has advanced life support capabilities to get you, hopefully to get to you within 2 minutes.
And either yourself and also Dr. Jardine, can you tell us about Narcan and really go into a little bit of how that does work? I mean, you mentioned about blocking, but can you tell us a little bit more about the drug and how it actually goes to work within the body?
Well, as I said, Narcan or naloxone is what we call an antagonist. It competes for the same receptor that the opiates do. So on the cells, there are receptors that take in the opiate. So what it does is it blocks access to that receptor. So the naloxone will knock off the opiate and then block the receptor so that the opiate can't work there anymore. Like I said, the inherent problem is that Narcan doesn't last as long as an opiate. So the Narcan may wear off, and then the opiate is still around, attached to the receptor. So they may need multiple doses of Narcan, and certainly, observation after they get Narcan.
So you can administer a second or maybe potentially third dose?
I've had people that have to be on a constant infusion of Narcan because they've had so much opiate on board that they have to have a constant infusion of Narcan to block the effects of the opiates.
The Narcan drug now is becoming more available through some pharmacies. Is it an expensive thing to own for an individual?
To be honest, I don't know the cost, but I can tell you that it is available in pharmacies to the point that we have had overdoses come in who were taken out of the bathrooms of local pharmacies because they go into the bathroom in the pharmacy knowing that there's Narcan just out there on the shelf, and hoping that somebody will be smart enough to get the Narcan and bring it into them in the bathroom. So they find that as a safe place to do opiates and narcotics.
The Samaritans are here tonight, and we're going to talk with them in a minute, but for the people who are using and maybe purchasing a Narcan from a pharmacy, they may think that they can self-administer it during a pinch, and unfortunately, sometimes drug users are in a group. So there's many people using drugs. Of course, we don't want anybody using that type of narcotic. But when an overdose goes into play, one of the problems plaguing action sometimes has been people around them have been afraid to call for assistance because they themselves may have been using illegal narcotics themselves. So perhaps between the Woonsocket Police Department, Captain Lemoyne, and our friends from the Samaritans group, Denise, you could talk a little bit about the Good Samaritan law and how that may be helping. Then I'd like to get into your hotline and the action that takes. But if you have anything, we'll start with Captain Lemoyne on the Good Samaritan law changes.
Well, under the Good Samaritan Overdose Protection Act, or Prevention Act, just as you said, if there is an active overdose situation and somebody calls for help, the police and rescue respond. We will not arrest that person for calling us for somebody using drugs based upon this act. Essentially, it's there to protect that individual and to immediately get help for that person rather than taking somebody into custody.
Is that a recent change?
It was enacted early this year.
Oh, great.
Could I just interject?
Yeah, absolutely.
I
Please
used
feel
my
free.
phone and Googled the cost of Narcan.
Mm-hmm.
It's about $15 a dose, so you're going to
Is
be...
that 50 or
15.
15?
Yeah, so it's, I'm sure everyone in the fair market has a
Yeah.
few extra cents on it, but like the doctor said to me, it's still more expensive than heroin.
Isn't that amazing? Thank you for doing that research. Appreciate it.
Trina has a question.
Yes, please do.
To Mr. Lemoyne, now what if the two persons are getting high and the one overdose, and the Good Samaritan law, would that go into effect?
Yes.
That person, even though they're both?
Yes.
Thank you.
Oh, thank you. Let's talk a few minutes with Denise Beniches from the Samaritans group. First, why don't you start out telling us what role the Samaritans play in the community and the state?
Well, the Samaritans has been around since 1977, and it practices non-judgmental listening. Now, that being said, the most popular program that we have that the average person knows about is our hotline, which unfortunately is not manned 24/7 anymore because we do not have enough volunteers. And so I want the public to, understand that, and we're always welcoming people who are diligent and who care enough and that want to follow the rules to think about becoming a crisis hotline volunteer. In the end, it's not really hard. It is about being kind. And so actually tonight I'm here instead of being at our opening hotline training orientation tonight. The second thing, though, is that the orientation of our program has actually changed And the hotline is not the biggest program we have. What has become our biggest program is community education. And our website went up in 2003. And in the first year, without even trying, we had 6,500 visitors to our website. It's gone up every single year, and last year we had more than 50,000 visitors to our website. Now that should tell you something. Now that being said, regarding the Good Samaritan law, people thought it was us. So that caused a little bit of confusion, and I actually partnered with Dr. McDonald so that we could get the word out about what people should do, because we were getting calls on the hotline saying, what would you do if we needed to report? Which our protocol is, so that being very transparent about it, we only call if the caller asks us to call. It is an anonymous hotline, we don't trace calls. And so if the caller would like us to call 911, we will do that, otherwise it doesn't happen. What I want everyone to understand, including the viewing audience, is to understand the role of how you get to emergency care. And I think that's really important, whether it's a drug overdose, suicide emergency. And you know, as we all know, it's a gray line. Rhode Island's 911 is one of the few in the nation that has a statewide GPS system. So if you look at our website, it says today, if it's an emergency, call 911, need to talk, call the Samaritans. And that is because of that GPS, and they can find people. Now that being said, it is the shortest distance for help in any community is to call your local police department, because they know who you are, where you are. But if you're not sure, call 911. They work every day with the local police department to help find people. And this is as important for caregivers as it is for the person who is in the process of overdosing. Caregivers call us all the time because they are concerned about their loved one. And if you're not sure what will happen and what the situation is, call the police department or call 911 and ask for advice. They are there to help you. Now that being said, what is the role of the Samaritans? We are there for people when they are in a crisis, when they're recovering from a crisis, and when they've recovered, when they're in care, out of care, and most importantly, when care is never going to be an option. And sometimes talking to a Samaritan volunteer who is non-judgmental can be the first step to going to the emergency room, to asking for the police, going to Anchor Recovery, to talking to your primary care doctor, to talking to a school nurse, to a social worker, to a trusted family member. And everyone tonight has talked about stigma. Well, we help alleviate that stigma and make it okay to ask for help. And the volunteers are kind and non-judgmental. And I want everyone to know that that is the role that we play in all of this. The website, however, is open 24 hours a day, 7 days a week, and with the amount of visits that we are getting on that website, it is actively used. And one of the things I wanted to tell the people that are here that wouldn't have known when I partnered with Dr. McDonald, and we started to get these phone calls from people asking us about the Good Samaritan law, I decided that we would post something on our website and post something on Facebook, and then to see what happened. And interestingly, from March 1st to March 24th, we had over 11,686 hits just on the drug overdose prevention page. We had over 2,200 hits on our suicide emergency checklist page. And if people look on the website and look under About Suicide, you will then see a drop down to a suicide emergency checklist. It's the same thing as if it was a drug overdose. It's the same protocols. That is a remarkable amount of people in a short amount of time that wanted that information. So we know that it's not scientific, it's not a best practice, it's just a snapshot. Then what we decided to do was to post on Facebook only to men, because what we know is that more men die by suicide than women. Let's see if we put it out there. And on that Facebook posting, we had over 52,990 impressions, 13,706 reached. Now these are the Facebook facts. And then people taking action. There were another 50 people that shared it. People want this information. Facebook was anonymous, the website's anonymous, it becomes the gateway to care. And for everybody that's in this room, I want everyone to know that I consider all of you in the suicide prevention business. The World Health Organization says the single biggest risk factor for suicide is the lack of connectedness. Everybody here and all of the programs that you do in the city of Woonsocket and throughout the Blackstone Valley and the state of Rhode Island keep people connected. The other thing is that Dr. McDonald talked about happiness, and when I heard him say that, it reminded me about hopelessness. And for all the people who are in the profession of helping people who are have addictions, if you ask them, are you depressed? They say, why do you think I take drugs? And we know that. There are 3 things we know about the truly suicidal, and imagine this to be with people who are drug addicts. They are hopeless. They believe that no one cares if they live or die, and in the end, they think they're doing everybody a favor. All of the people here care about the suicidal. They care about the people who are drug addicts, and the most important thing that we can do tonight is educate the viewing audience, educate the people here, get connected to the services that are here. They all care. We all care. Thank you.
Hearing those numbers and your description of the characteristics of somebody in that position, I can imagine that telephone voice being crucial. I'm saddened to hear that the volunteers are down. You have an opportunity, thanks to the good people at Capital Television, to reach people across the state. So take an extra minute. Talk about how somebody can become a volunteer. For the listeners who are and viewers who are watching this, maybe they're thinking, gee, maybe what you look for within the person to become a volunteer and how they can connect with you.
Well, I appreciate the opportunity. Anyone can be a volunteer. You have to be 18 years of age and out of high school. We've had police who volunteer for us. We have college students. We've had doctors and nurses. We've had laborers. Anyone can be a volunteer. What you have to be is patient, kind, and follow the rules. We have a 21-hour training program, and if you go to our website, which is www.samaritansri.org, you will see a section about donate and volunteer. Under the volunteers part has the schedule and all of the criteria. And again, it's a 21-hour training program. It's not for everybody, but for those people that want to make a difference, you couldn't find a better place to do that.
21 hours spread over multiple days, I would assume. And where is the call center located?
We're in Pawtucket.
Pawtucket, Rhode Island. Okay. Thank you for the work you do. I'd like to talk with the folks here behind the podium, for some of you on the right side of the room, and talk a little bit about prevention. Again, we have we have Pamela Shea here and Diane Dufresne. Let's start off with the role of prevention in substance abuse. Whichever one would like to go first.
Well, we clearly know that prevention works. We heard Dr. Stenning talk, and the data clearly shows that it does work. The prevention coalitions, they base their strategies on assessment and problem identification and develop solutions such as evidence-based strategies to reduce the problems. What might work in my community, Lincoln, Cumberland, North Smithfield, might not work in Woonsocket. We know our communities, and we know what problems exist and what target populations to capture. Some of the strategies that we use are, we do youth development programs, parent programs, local policy changes with our law enforcement. We develop newsletters that go out to the schools for the students and the parents. The prevention coalitions are the only entity in the state that deal with prevention on a community-wide perspective, meaning we collaborate with all the sectors in the town, law enforcement, parents, schools, faith-based communities, elderly. That's what really makes it work. That's the connection that's so important, that makes prevention really, really stand out. Everyone has different programs in the community based on their needs assessment, where the gaps lie in the community. So it's a targeted approach. And like I said, what works in my community might not work in another community. But we truly focus on what the need is for each community.
I would imagine, besides community to community, individual to individual, those parameters must change.
Absolutely, absolutely. We target individuals, groups as a whole, elderly populations, parent support groups, kids that are at risk. I have an after-school program that I do every other week at the Family Literacy Center, which is a wonderful place to go if parents or students need support. There's so many services there. It's free. It's a wonderful place to go after school if students need that extra attention on an issue that they're facing.
You talked about, and Diane, if you wanted to jump in, I don't want to cut you off on that question, but you mentioned different strategies where different people. You cover likely maybe a few of the different strategies that may be in use.
I mean, we have, Rhode Island has rural populations, suburban populations, and urban populations. So there's different sectors that are targeted in each of those, and that's why different communities are focused on different populations. I'm not sure I'm getting to your question, but what's running in my head right now, because I work in both treatment and prevention. So just to give a holistic kind of overview of what we're talking about when we talk about prevention is it's part of a continuum. So you want to start with prevention, as Pam said, in a holistic sense where you're reaching out to an entire population, hopefully in the early years as children in elementary school, taking it through high school, and on to elderly. But prevention is the first step, and that is focused on education, raising awareness of drugs, of anything in the community that has to do with substances. Prevention also involves violence prevention. It also involves sexual education. It involves truancy prevention. So you can go on and on and on with social ills, and that's what we're doing, because it isn't just substance abuse in a bubble by itself. Everything, we're human beings, and all those things are intertwined. Prevention is I just wanted to get to this whole thing here, but prevention is the first tier, and treatment for people that have substance abuse, actually we call them now substance use disorders. This is the newest terminology, because we don't want to label people saying they're substance abusers. I could take a drink and not have the same effect as you taking a drink, so it's a substance use disorder. But anyway, so prevention, that's for the whole population, but some people are still going to be predisposed to have a problem regardless. So then there's treatment, and then there's recovery. So it's kind of a continuum, and we want to keep that whole continuum going.
Okay.
Prevention, treatment, and recovery. And what Pam and I do is called primary prevention. So when we talk about Narcan, which is what we're talking about here tonight, that's more of an intervention. It's prevention in the sense that it's preventing death, but it's a very small step. It's an intervention technique. What we're doing is primary prevention on a much wider scale. So I just wanted to make that distinction.
We wanted to get to those kids before they get to that point, to educate them about the dangers of opioid overdose.
Hopefully someday, so they don't have to see Dr. Juddy.
Exactly, so like Diane
Offense,
said, get
Doc.
them when they're young.
You mentioned seniors there, and that caught my attention, and we heard from the good doctor earlier about over-prescribing various pills for various reasons, but we also know that seniors receive a lot of prescriptions. Unfortunately, sometimes, even through DEA, that's a method how they can get onto the street. I'd like to talk a little bit about prescription drug abuse with you in the cities and towns throughout Rhode Island and the United States, but is it a different strategy to employ dealing with prescription drug abuse versus some of the heroines and cocaines, marijuanas?
Well, as far as the elderly go, one of the things that's done statewide in many communities is called a brown bag day, where you have elderly people that just take all their drugs in to show us and professionals what they are taking, because one doctor won't know what the other doctor is prescribing, whether they themselves, the patient, doesn't know that it's an addictive medication. So there's a lot of education that goes along with that. What has happened recently, in the past year almost, is the new system, and I don't know if the emergency room doctor down there, because I used to work the ER too, but there's the new system online now, where all all patients, doctors can plug in, so that a doctor can look up at any time to see all the medications that somebody is on. And that's like a godsend, because that reduces duplicate prescriptions and...
The limitations of that is that it does not include any behavioral health medications, so if someone's prescribed a benzodiazepine, that may not be reflected in the database. It's medical only, it's not behavioral health at this point.
Oh, really?
Yep,
And that would include any and all psychological...
psychotropics, correct.
Yep.
Mm. Well, then that's something that we need to address.
Go ahead, doctor.
The common pain medications, opiates, narcotics are included, so we can see, we can get a snapshot of, to see how many people have, how many prescriptions they've filled and numbers and et cetera. Yeah, like Dr. McDonald was saying, you don't need 90 Vicodin for a sprained ankle or whatever, so, we can see what kind of prescription record they have and whether or not they, are maybe overusing.
I'd like to get into the personal side of this, and I guess it's all personal, but recovery and what families and individuals go through. And we can maybe start with Michelle Potter or Tim Potter, and Carol, if you have anything you'd like to jump in, but let's start with a simple one. How does one even begin recovery? Not simple, huh?
Not simple.
That's pretty much it's a really loaded question. For me, I've been in recovery since July 5th, 1994, and strangely enough, I went to detox and treatment at Roger Williams. Diane was not there then. There was a woman by the name of Pat, and the way I got there was kind of strange. I have my own spiritual thoughts about it, but I do believe that there was a little bit of divine intervention. I was faced with losing my children, and not by the state of Rhode Island, but by losing my children and some other people in my life, and came to the realization that I really did have a problem with alcohol. And my problem kind of went from drugs in the 70s and to alcohol after, when you kind of get older and you start having a family. It's more socially acceptable to drink than it is to snort a line of cocaine. So it's a difficult journey at best. The fear is overwhelming. The shame is overwhelming. The stigma is overwhelming. Everything that was said over here about, nobody cares, nobody wants me, no one's going to miss me, all those suicidal thoughts, if you will, those are prevalent in most people that I know, and that's been my experience at what's called the bottom, And, I'm grateful every day that I reached that bottom in a manner where I was surrounded by people that cared about me. And it's really important that I say that, because most of the people that I deal with on a daily basis don't have that great of a support network. And so when they come to see us, that's the first time that the support network starts actually working and may enable them to actually pick up the phone and call a parent or a sibling and say, look, this is, I've reached the end, this is where I'm at. Sobriety is not an easy journey by any stretch. I'm not going to sit here and say that 20 years came easily. It didn't. But the adage of one day at a time is certainly part of my recovery. And I'm vigilant about it because I don't ever want to have to get clean and sober again. I can't put it any more strongly, ever. It's a family disease for sure. Each one of you sitting out there, you may not think that you have someone in your family that's in the throes of addiction, but I can bet if you branch out a little bit, you're going to find somebody, and that somebody's going to need some support one day. And I guess that's why I do what I do. If somebody hadn't forgiven me and given me the support, then where would I be?
Now, again, anybody in the panel wants to get in these last few ones, please feel free, but this is perhaps some of the most important discussion we'll have here tonight for families who are dealing with addictions, either with themselves or with their loved ones. And for sometimes, especially parents, especially if you grew up square, you didn't experience things yourself, it's hard for us, I'm a parent, to recognize signs within our kids. So if you could just throw a few things out there for parents and family members and loved ones to watch for between family and friends, that'll be a true sign that there's a problem. A couple of things, please.
I work with kids, so I'd like to throw out as a social worker and a therapist, one of the things that we advise parents first and foremost to see is if we see any kind of personality change in kids. Once kids start either drinking or using drugs, they become secretive. And if you've had an open relationship or even a difficult relationship with your kid, you're going to find that once they begin using, it becomes much more difficult to get anything out of them. There are also residuals that get left behind. For a kid who's smoking marijuana, you may see cigar wrappers, you might see Visine that you never saw before, you might see cans and bottles. But mostly it's about if they're changing their peers, if they're changing their habits, if they're not as enthusiastic about either their school or their sports or their hobbies or their recreational activities. Those are the things that we look for. Adolescents themselves are already going through a very difficult time, so the personality changes could occur anyway, but you don't want to take drugs or alcohol out of the mix. So as a therapist, one of the things we do is talk about how you can sit calmly and safely to talk with your kids about what's going on. So that's from a clinical standpoint.
And the information that you're hearing here, I just don't want to give the impression that it's strictly for children. It could be your husband, it could be your wife.
Absolutely.
There's no age, there's no race, there's no creed, separation.
Right. I want to say that as a person who provides treatment on a daily basis, we talk about stigma, and as much as perhaps the people in this panel no longer feel the stigma, and maybe folks in this room have felt that lifted, there still is a stigma about either being a person who uses drugs and alcohol in an unhealthy way, or people who go to mental health treatment or substance abuse treatment. And so it's imperative that all of us carry the message that treatment works. There's lots of kinds of treatment. You can go anywhere from detox to residential to an intensive outpatient to individual to group to family. And it goes on and on. It's the positive interventions that work. And I always say that trying to find recovery, whether it's mental health recovery or substance abuse recovery, is like climbing Mount Everest. It's incredibly difficult. And there's no way to get to the top really fast, and people die along the way. So it is an enormous challenge, and we have to help families understand that if they have someone in their family, husband, wife, child, grandparent. What's really important is to understand that this is a struggle, and we want to be the light in the room that helps people not bump into the furniture. We can't take them to the top. They have to find that way themselves, just the way we heard tonight in testimony.
You recognize the sign, you see an issue, but unfortunately, you can't always, mandate that treatment is going to be taken. And not only does it derail the substance use disorder victim,
All right.
got that one there, but it can also derail the families, whether they're at work or
There's a
caring
lot
for
of
them.
collateral damage in
Yep.
substance use.
Yep,
There's
yeah.
a lot of collateral damage. Families fall apart where there should have been strength, there is not. But the sign I want to put over my office door is you could lead a horse to water, you can't make him do therapy.
Right.
So the person has to want it. And whatever it is that motivating feature, the person has to want to be clean. I see a hand there.
I have to say something. What you say about finding out how they're using drugs or whatever. I have a mentally ill child. He's 21 years old now. He was drug addicted from his mom and dad, whatever. And my problem is right now, all these young kids are smoking marijuana. Now with him, he smokes it, but he seems like he just can't stop. He's supposed to go to the drug abuse treatment, whatever. How am I supposed to get him the treatment if he doesn't want to go and really he doesn't know that he's sick enough?
There's a model of change that we call stages of change, and the first stage is called pre-contemplation, and that is the person who doesn't recognize that they have a problem. And there's no good answer. I don't have a quick answer for that. In the 12-step model, we often see that people hit the worst part of their life, which is hitting bottom, and then at that point they recognize that their substance use has become unmanageable. But until he has hit his bottom, he may have no motivation to change. In my practice, I work at Community Care Alliance. I've been there almost 10 years, and I will tell you that it takes people many times to go through the interventions to finally recognize that they need to make a change. Secondly, mental illness and substance abuse is called co-occurring, and the incidence of co-occurring disorders of substance use and mental health are like a hand in a glove. And so sometimes what you have to do is bring the person in for their mental health so that they can feel better and happier about their life, and allow the clinician to find their way into healthier ways of dealing with their mental health rather than picking up a drink or a drug. But is it a challenge? It's been a challenge since the first guy in the back of the cave sucked down some fermented grapes and said, "Ooh, this is fun," and everybody else said, "That's a problem."
And can I just say, anyone who has a substance use disorder has a brother, a sister, a mother, a father, a son, a daughter, whatever, that is being negatively affected by their substance use. As has been said here, you can lead a person to therapy, but you can't make them do it or something. But you can help yourself, because Al-Anon is out there and Nar-Anon. They're free programs, they're support groups. They help you to understand why you react the way you do, how to change your behavior, how to focus on yourself and get the focus off that person that's using. Because you can't make them change, but you can help them change.
Can I add to Diane's? We're talking about family difficulties. And one of the things that led me to go to Dr. Yearwood and Chief Carey and Lisa is that it was personal. And, you know, it's good that we have all the professionals here. And as I'm sitting here, I've learned a lot. And one of the things I had to do for myself, I had to educate myself. And once you educate, you know, I bought books and watched medical shows, and drug addiction. One of the things that I learned was that first, Dr. Yearwood had said, we have to acknowledge there's a problem. And then, because we have a lot, and Dr. Yearwood said one of the things he mentioned was about, are they really functional? So I've learned that addiction, it was a disease. It kills. It affects family members. It affects your community. It affects all of us. And one of the things, another thing that I learned is that we have to talk about it. A lot of us walk around here in our families and we know that they're addicted or there's a problem, but we act like we don't want to see it. And I had to teach myself to pay attention. Things wasn't right. And, and over the years, I've seen friends that have died from drug addiction. We never admit that it was addiction, but the cause of death was because of the drugs. And it goes on from generation to generation, and our children are seeing it. And I didn't realize how young the children are doing it in elementary and middle school. They're doing it. And they're learning from us as adults. I know people that are in their 40s, 50s, and 60s, and they're still doing the drugs. So, we have to educate. We have to recognize and share with others that there's a problem here, and it's in our community. A lot of people aren't here tonight because a lot of us don't want to face the problem of addiction. But that's what it's called. We need to heal our community. We need to educate our community. We need to educate our families, and we need to recognize there is a problem. We don't know. Someone had asked, are we targeting certain communities? And I said, we're targeting all communities. You don't know what your neighbor is doing. So we all need help. And it's personal. How does a family member handle addiction to a loved one? We share, like they said, we have to be kind, loving, but we have to acknowledge there's a problem. And we have to share with our loved ones that there's a problem so that they can go and get the help, or we can help them seek help that is needed. It's sad. It's real. I learned this is real life. This is real. People are dying. When the chief ever told me it was 60 people that overdosed, but 10 died, I said it was 60 too many. I don't even know them. And I don't have to know them, but I have a concern for the addiction that is in our community. We need to recognize it.
One of the things I found interesting as I was shopping in the dollar store the other day is in the cashier aisle was a drug test for marijuana. As a parent and somebody who may be considering this, are those effective tests that are out there now on the market?
They are. You can go to Walmart. They have a huge array of tests. They have 5-panel, 7-panel, 10-panel, and they have about a 99% accuracy. I mean, they're not as good as a blood level, but they will be reliable, especially for the drugs that we're talking about. It's not difficult to test for THC, cocaine, or any of the opiates. They're pretty clear. What they won't do is discern in terms of the opiates, was it a Vicodin versus was it heroin or something like that, but they're pretty accurate.
Okay, at this point, I want to thank the audience for their patience. Are there any questions out of the audience for the panel? And I would just like to take a few moments and just go down and offer the panelists a final word this evening, and then we'll call Lisa up. I will start with John Kukowski, if you have a final word for the people here tonight, sir.
Just thank you for the invitation, and I think working together collectively, we face the challenges ahead to be successful.
Thank you. We'll go to Captain Mike Lemoyne from the Woonsocket Police Department.
I'd just like to, again, thank everybody for being here, thank our partners. I think we work well with our partners that are represented here, and just let the community know that the Woonsocket Police Department is there for them, and don't hesitate to call.
Deputy Chief Roger Perot, the Woonsocket Fire Department.
I'd also like to express my appreciation for the invitation tonight. And once again, we're there 24/7. If you have questions, if you need any help whatsoever, don't hesitate to call.
And Dr. John Jardine from the emergency room, Landmark Medical Center, now owned by Prime Healthcare.
Yes. Thanks for inviting me as well. You know, we're busy enough in the ER. We could certainly do without seeing some people with you know, substance use issues. So, but we of course are there 24/7 as well.
Thank you, Doctor, for your time. From Community Care Alliance, Pamela Woonsocket.
Hi. Okay, so thanks again for having me here. I really enjoy it. I learn something every time I do this. I do want to say that Community Care Alliance has what we call open access, meaning if today you recognize that someone needs counseling, they can walk in tomorrow morning anytime between 9 and 2:30, get an assessment, and start the process.
Thank you. Michelle Harder from Anchor Recovery and Community Center.
Thank you, Lisa, for the invitation. I would probably leave it, my closing words would be erase the stigma and more people will get treatment, and that's what it's all about.
Tim Potter.
All right.
Hey, Tim,
As a
how are you?
person in long-term recovery, it takes self-will. It takes understanding that a community, education, and a teamwork of everybody combined in your life to gather willingness of your life, and everybody combined will make a difference. And you all showing up tonight, I commend you, and I want to thank everybody that's shared their expertise and their dedication to prevention, education, and cooperation with recovery. And this is exactly how we're going to change. And I want to thank Pam for inviting me, and anytime I can be of assistance, I'm more than willing. Thank you.
Carol Wilson Allen.
I just want to say thank you, Lisa, and thank everyone for their participation. And I've learned a lot here tonight, and I'm thankful for that. So I hope that we can all take what we learn and go out and help our community and families.
The Executive Director of the Samaritans, Denise Beniches.
I'd like to thank everyone for inviting us because sometimes we're the ones that people don't want to talk about. But that being said, I'd like to thank Lisa, and I'd also like to thank Mayor Lisa Baldelli-Hunt. What has been remarkable since I've moved to Woonsocket is the caring that this community has for each other and for their institutions. And one of the things that you've done is you're looking at the community against all odds as a whole community. You're not picking on just one piece. You're looking at the school programs, you're looking at the senior programs, you're looking at hospital care. Most importantly, you're looking at economic development. And I honestly believe, and I said something to somebody earlier, I said we need jobs. We need to bring a sense of normalcy back to the community so that people have the hope that tomorrow can be a better day. So I appreciate how you've brought everybody together and continue to do that. So I want to thank you very much.
The Cumberland, Lincoln, North Smithfield Prevention Coalition, Pamela Shea.
You know, these town hall meetings are so important, and I've had a few with Lisa over the years. And you know, the discussion does not stop tonight. This is not the end. We need to continue to spread this message, and that's why I love working in prevention, because I know that we're making a difference. And I know all of you here and on the panel came here tonight because you care. You care about your community, you care about the people that you live with, that you work with, your families, and so on. We need to have more of these town hall meetings, but we need to fill the room. We need to have more discussions about what's going on, because this is a reality. This is not going away. This is not turn the other cheek and it's going to be gone. We need to continue to educate and to spread this message and to let people know that there is help available, that there are resources available. I mean, if you look at this panel, we all are passionate about our jobs. We all do different things, but we're all similar in so many ways. We care about people, we care about making a difference, and that's what really matters. Making a difference in someone's life, making that change be positive.
Recovery, prevention, treatment, recovery. We all have to work together. Thank you.
Two more last words from me, and Lisa Casafaro will say good night. Thank you for attending. Thank you, panel. And as I always say every week, weekday at 4:30. Choose life and take care of one another. Thank you.
So I don't have a lot of words. Mayor, thank you for staying. You have always been such a strong supporter of prevention, treatment, and recovery, so thank you for being such a leader. And thank you to everyone else for coming and joining